of all, thanks for everyone joining tonight and listening later. Dr. Jennifer Phan is a board-certified gastroenterologist serving as the medical director for Hoag Irvine Advanced Endoscopy Center. She's also the director of Bariatric Endoscopy and the program director of the Advanced Endoscopy Fellowship. She completed her gastroenterology and advanced endoscopy fellowship at UCLA and specializes in complex diagnostic and therapeutic endoscopy, including management of pancreaticobiliary diseases through the use of endoscopic ultrasound and ERCP, removal of large polyps through EMR or endoscopic mucosal resection, and then endoscopic management of GERD and Barrett's esophagus and complex defect closure via endoscopic suturing. So thanks for joining us today.
It's a pleasure, and thank you for the invitation. I'm going to go ahead and share my screen, so let me know if you see the slides.
Yep, we're good.
Okay, fantastic. So it's a pleasure to be here. I know that this is primarily seen by surgical residence fellows and some attendings. So thank you for enduring the advanced GI perspective. So what I'm tasked with here today is to talk about endoluminal management of colonic strictures. So very little, almost no slides at all on the surgery perspective, since you all know that better than I do, but here to give you a perspective from what we can do from a GI standpoint or from a colorectal standpoint endoluminally. These are my disclosures. So colon strictures in general are defined by their etiologies as either benign or malignant. And I won't spend too much time on this because I really do want to dive into the endoscopic management of these strictures. But what we know is there's a big variety of benign etiologies. So I'm sure you all have seen some acute diverticulitis causing a stricture, ischemic colitis, radiation colitis, anastomoses or resections causing stricturing, and then some that are caused by what we are doing. So for example, when we're doing large endoscopic submucosal dissection, so ESD, where we're taking a large either high grade polyp or an early stage tumor and we're resecting it, if we're resecting more than half the circumference of the lumen, there runs the risk of potential stenosis. Again, this doesn't happen so often. Most happens commonly, say if you're doing it in the rectum, um, that a stenosis can happen, but we know that we're doing enough now in the American population that we are seeing some rates of stricturing related to ESD. And then very classically, we have our malignant etiology. So, colon cancer related, rectal cancer related etiologies. So in general, what are we looking for on imaging? And the reason why I want to spend a couple minutes on radiology and the workup is because it really matters what the patient looks like on imaging and how they present as to whether we should undergo an endoluminal approach versus a surgical approach. So what are we looking for on imaging that says that we have a colonic stricture that's causing an obstruction? So we're looking at colonic and cecal dilation, so whether the colon is dilated past 6 centimeters or the cecum is dilated above 9 centimeters. We're looking for relative paucity of gas in the rectum and proximal colonic fecalization. There's also, you can have plus minus small bowel dilation, and that really is more dependent if you have a competent IC valve or if you have a colonic volvulus. And so for some patients, you can have significant fecalization of stool all the way through the small bowel because their IC valve is very accommodating. And so you can see that on imaging. And so what we see here in a radiograph is you can see that as we see a little bit of air in the distal colon, we see, and typically this is very uncommon that you can actually see such a tight area of narrowing on an x-ray, but what we see more classically is more proximal dilation of the colon, and then you can even see some fecalization here in the proximal colon. On CT scan, you can see the same things, but to a much greater detail. So here you can see an obstructive endoluminal mass here that is pretty much constricting the entire lumen. You can see dilation and here that fecalization of that proximal small bowel. What we can also see here, and what I'm assuming you all can see as well, is this mass has metastasis to the liver. And so what are it's atypical that we just take an x-ray and we go from there. An x-ray is a great place to start that says yes or no, let me be suspicious for some sort of obstruction, but innately we all like to go in with more information. And so a CT scan is really quite helpful for this. And the use of IV contrast doesn't significantly increase the sensitivity of us being able to evaluate for a potential mass or an etiology, but it can help us evaluate for ischemia, which is often important because if a patient has significant ischemia on CT scan, we may want to discuss multidisciplinarily whether this person should go to surgery or should undergo the risk of endoscopy with air insufflation. So innately, endoscopy remains the gold standard to evaluate the etiology of a stricture. There's nothing much better besides a less invasive option to visually look at what a stricture can be like. And again, what we're looking for is this a malignant stricture or benign strictures? There are gray areas in between where certain benign strictures look malignant. So for example, in the setting of inflammatory bowel disease, you can see a stricture that is quite ulcerated or deeply ulcerated that could mimic a malignant etiology, but that's why endoscopy becomes so helpful. Is not only is it direct visualization, we can biopsy at the same time, and then we can also potentially therapeutically intervene. However, there are some cases, so 5 to 15% of cases, where the stricture is so tight that we can't traverse it endoscopically. And why does this become important? So it's not uncommon that the ends of a stricture may look benign, but the center of the stricture is malignant. And so if a stricture is so tight or so high grade that we can presumptively say that a colonoscope does not traverse a good portion of strictures. Let's assume that we're using a gastroscope, which is significantly smaller in diameter. And for certain strictures are so tight that a gastroscope cannot traverse, then we're left with a noodle scope, a 6 millimeter noodle scope. And there are times when even a noodle scope cannot traverse a stricture. We can only then biopsy the ends, the distal end of that stricture, but we can't confirm with certainty what's in the middle of that stricture. And the pathology is typically at the midpoint of the stricture itself. So although endoscopy is fantastic, there are certain limitations, and often we won't know those limitations until we go in. And so what other radiological options are there if we can't undergo endoscopy for reasons that are self-selecting to a patient criteria, they're too sick to undergo endoscopy, etc. What other radiological options are there? There used to be one that was water-soluble barium enema. It's no longer recommended. So the reason why the enema is no longer recommended is that you can risk intraperitoneal contamination if there happens to be perforations or microperforations related to the stricture or the obstruction. Also, once the enema is given, it potentially interferes with other subsequent cross-sectional imaging or with endoscopy. So remember, if barium goes in, we can't scope for a day because if you suction in the barium into the scope itself, it's going to destroy the inner lining of the scope, or it's very hard to clean out afterwards. And so that's a contraindication to going in right after barium is given, either from up top or from below. The next is CT colonography. You can kind of see that version in C and B. And so CT colonography requires bowel preparation, right? So there's no, you can't do it without a bowel prep of either some Dopalax or some Picosilex or some, a little bit of Miralax. But again, a lot of patients are so obstructed that they can't undergo a prep. And so the utility of the CT colonography significantly goes down if you're unable to prep for the scan. So the patient selection becomes very important, whether we say this patient has a stricture, we think it's acute, or we think it's benign, or we think it's malignant, which ones need to go to surgery and which one needs to go to endoscopy. So this is where history, physical examination, and the CT imaging typically becomes so important, whether we suggest the etiology and the best therapy for these strictures. And so again, there are multiple surgical options. I won't go through that, but the real question for us for this purpose of this lecture is which ones are appropriate for the endoscopic option. And in general, the tool of thumb is location is so important. So remember, a gastroscope length is around 103 centimeters. A colonoscope length is around 135 to 165 centimeters, depending on if you have the extra long colonoscope. And remember, if you're trying to do things, and we'll get into this, like stenting, you can't do that through a colonoscope, right? It needs to go through a therapeutic gastroscope. And so location becomes an important factor when we discuss what can we do and what is the intent of what we're doing. So next, I'm going to go into our endoscopic management options. And there are many and there are a growing number. So innately, the first endoscopic option, you're going in, you're taking a look at the etiology of the stricture and you see a stricture. What is the minimum thing that you can do that's the least invasive? And that's balloon dilation. So balloon dilation is the first treatment modality option for benign strictures. So these are your anastomotic strictures, these are your ischemic strictures, your radiation strictures. These are the balloon dilation is a great option. There have been multiple studies. People have been doing balloon dilations for years, for decades now. So we know that there are certain predictors of good clinical success and those that are predictors of poor clinical success. So certain predictors of good clinical success include the fact if the stenosis is narrow, so around a centimeter in length, and we'll discuss in the next slides why that is, and if it's an anastomotic stricture, because innately anastomotic strictures are typically very short and narrow in length as well. And so they're really able to undergo kind of good radial force to break and can respond well to a balloon dilation. There are certain features of poor clinical success, and there's a long list of them, which is why the balloon dilations are really only appropriate for certain strictures. So, for example, if you have numerous strictures, like a Crohn's disease patient that has numerous strictures, a balloon is only, there are various lengths of balloons. There's short balloons and long balloons, but even if you use a long balloon, you're not going to really be able to dilate well beyond 3 to 4 or 5 centimeters at most, right? Because your radial force of the balloon doesn't go towards the tips of the balloon. So even if the balloon is, say, even 10 centimeters long, the 8 to 10 centimeter length and the 1 to 2 centimeter length in the beginning and the 8 to 10 at the end, they don't have the same radial force as right in the middle of that balloon. So your true dilation capability doesn't span the entire 10 centimeters, even if you had a balloon length that was that long. It's really that middle segment that has that true radial force. If there's a complete obstruction, a poor clinical indicator really can't get the balloon fully in across the stricture. And if you can't get the balloon across the stricture, same ethos, you're not going to really dilate. If there are fistulas associated with the balloon, in general, dilation is not a good idea. If there's active inflammation around a stricture, remember, a balloon dilation doesn't give you a significant amount of control. We think we have great control, but there are other endoscopic options that have much more control than a balloon dilation. So I'm sure many of you during your general surgery rotation have seen where people have done balloon dilation, say, of an esophageal stricture, and then it's caused a perforation, right? Because these balloon dilations, they are not good at giving you tactile feedback when you're dilating beyond a certain point that the lumen is capable of stretching to before perforating. And so obviously when patients have inflammation, the risk of perforation goes up. If patients had recent surgery, again, these are really fresh sites. We tend not to dilate. The same ethos goes when we're dilating across any new surgical anastomosis, even biliary strictures for, say, liver transplants. We don't balloon dilate within the first month because these anastomoses are so fresh and not well healed. Any tight angulations, remember, a balloon when it fills with saline straightens. So when you have an acute angulation, the balloon wants to straighten when it dilates. And so again, risk of perforation. And again, malignancy, not good for balloon dilation, mostly because it's not going to do anything, right? A malignancy has very soft tissue. It's the tissue that's endoluminal tends to be quite compliant because it's, all the villous soft fluff that's there and some ulcerations. And so you may think that you're dilating something, but you're not really breaking any sort of scarring that's happening. All you're really doing is kind of pushing tissue towards the walls that once the balloon is deflated and removed and give it an hour or two, it's going to kind of come right back in. So for clinical considerations, and I'm going to play this video as I talk about it. So for certain clinical considerations, remember that, and I've alluded to this, dilations work through a radial vector force across the stricture. So again, the center of the balloon has the best radial vector force. And so once it pushes across the stricture, right? Whatever breakage happens immediately at that time. Once you deflate the balloon, if there hasn't been any sort of disruption to the tissue or to the muscle or to the scar, then you kind of scar back down again. And so it's not unrealistic to expect that you may require multiple serial dilations, at least 2 or 3 endoscopic interventions if you're trying to dilate a stricture open. A lot of patients get immediate relief. Again, that's what we say, kind of the balloon opens it up and it has this temporary force with it. But as long as it actually breaks something, then you actually get the long-term relief. That's why you see only 44% actually get long-term relief. And the most success is in patients with anastomotic strictures because of the scarring. So you're able to break the scar up with the balloon. So what we see here, and if I go back just a little bit, is this is an anastomotic stricture. You see a balloon traversing the stricture easily across. Now, if you cannot traverse the stricture, and we'll see this in the next video, it's important to do things that are safe. So if you can't easily put a balloon across, or you've not been across the stricture before, then you shouldn't advance a balloon and dilate. So in this stricture, clearly this person has gone through the stricture, knows that it's a short stricture. They're balloon dilating the stricture open. And what you see here is you want to observe the dilation. There's a reason why these balloons are see-through balloons and they're not opaque balloons. The reason is so you can see the dilation. I'm going to stop right here. And you can see that the force of the balloon is the highest in the center. You can see wide out of the area that it's applying this radial vector force against. And how you see how you see into the balloon and observe your dilation is you actually want to bring the balloon as close to the face of the scope as possible. Then you want to rotate the scope kind of with your right hand inwards a little bit, so towards the left. And then you want to push your dials in. So big dial back, little dial back as well. So you're kind of looking into the balloon. And the reason why this is important is this is a nice controlled stricture. This is as controlled of a stricture dilation as you can get because you can see as the tissue responds. So for example, if I'm looking into this balloon and I'm observing that I see a lot of kind of this red tear and it's kind of coming up and up and up and up and up, I'm going to tell my tech to stop, right? Or if I see that this white is coming up and up and up and up and up, then I'm going to get concerned that am I perforating? Am I causing kind of separation of the walls with my dilation? I want to stop, right? Because what I want to see when I'm observing the dilation are short kind of cuts along the stricture here. So what you see here is you're using water, so you're kind of blinking, as we say, with the scope to better visualize as you're visualizing the dilation. And then as we come down, now we can actually go through and see where we have good break points, right? So there was a good break point here around the 1 o'clock position, a good break point here on the 7 o'clock position. Now, the question that we get often is when do you biopsy the stricture? You always want to biopsy after. And the reason for that is this is not the best control dilation that you can have. So you want to biopsy after you've broken. So if you were to say take a deep biopsy and then dilate, that's a weak point there. So you're going to get a lot more breakage at the area of the biopsy than you would kind of at other areas that may typically have needed more of a break, and you risk perforation in that area if you had deep biopsied. And so if you have a chance, you want to biopsy after. And then you can use a small 6 millimeter balloon, right? Or 6 millimeter, sorry, a scope to then go through the stricture and visualize the entire length of the stricture if you can after dilation. So what if you cannot go all the way through, right? And you still want a balloon dilate. So you can see this is another tight stricture, very, very tight stricture. What you want to do is make sure that you get a wire across. And it's very common that, especially if you're dealing with a malignant stricture, it is very important not to force the wire across. So you either want the wire needs to glide in very easily, or you need to do this under fluoroscopy. So what you see here is that's not a dilating balloon. It's just a balloon that we use to occlude, right? And here we're trying to just auto dilate the stricture with the catheter of this balloon, right? This occluding balloon. And under fluoroscopy, if you can guide the wire through, right? Then you can open up your balloon and then you can inject contrast. So you can see not only the length of the stricture, but you can ensure that where your wire is more proximally, that it is indeed within the lumen, right? So in malignant strictures, and if you're forcing the wire, right, you may not know that you're in a place that's unsafe. And if you have a small wire perforation across a malignant stricture, and that's all you've done, and you've confirmed on fluoroscopy, hey, I'm no longer in the lumen, you didn't do too much wrong there. The wire is so small, pull back the wire, image them again, make sure, give them some antibiotics. Innately, they're probably going to do okay. But the risk here really is if you believed your wire location and then you dilated across. So now you've just created a very bad perforation in a potentially a malignant stricture, right? Not a great thing. So that's why if you cannot see across the stricture, make sure to use a wire guided balloon. Make sure to use some fluoroscopy. And if you don't have fluoroscopy, but you can fit a 6 millimeter scope through the stricture, then what you do is you put your 6 millimeter scope through the stricture, you put the wire across with the 6 millimeter scope, you exchange out your scope, and then you over the wire put in your gastroscope or your colonoscope over the wire while keeping that wire in place. So now, because now you know you've endoscopically confirmed that the wire is in the lumen proximally. Again, you want to center the balloon across the stricture to prevent slippage. And after you remove the balloon, you want to examine the stricture carefully. And remember, the balloon ranges from 6 to 20 millimeters in length, and you really want to communicate with your GI tech. Hey, how do you feel at 10 millimeters? Does that feel too tight? How does that feel at 11, at 12, at 13.5, at 15? How does that feel? And again, you want to make sure that if your tech is a little bit newer, remember we're going through a lot of turnover with staffing, that you feel it yourself and you know what that feels like. So again, an occlusion balloon here, you're using your wire to get across. And what you see here is after when you dilate, you're going to visualize your dilation. And here what's happening is you're using the balloon to pull you across that stricture if it feels compliant, right? So the balloon has now pulled you across that stricture. And again, it's only if you feel safe when with the balloon going up, and you're typically not using a gastroscope or a colonoscope in this setting because of how tight that stricture is. Okay, next question is stenting. So the question is, can you put a fully covered stent into the colon? The technical answer for a fully covered stent, again, where all the lattices are completely covered, is the technical answer is yes, I can put a stent anywhere. The clinical relevant answer is likely no. And the reason for that is, so the advantage of putting in a fully covered is the fact that if you have something like benign disease, technically a fully covered can then just be removed, right? It never embeds into the tissue. It's a removable stent. We use it in the foregut a lot for like esophageal stenoses. Say you had a lot of reflux, then you became stenotic. You want to use a fully covered stent because you want to remove it one day. So the advantage is it's good for benign disease. And if you have something like you wanted to resect something not have a significant resection field, then you can put a stent in, remove it, and then ideally then just resect a little bit. But the huge disadvantage here is the kind of unacceptable high rate of migration. So if we look here to the right, this was a small study. 43 patients had occlusive or subocclusive symptoms related to colonic stricture. A lot of them had anastomotic strictures. Again, clinically success really high, but look at that migration rate of 63%, right? The stent only staying in for 21 days, and 50% had recurrent obstructive symptoms because of this high rate of migration. And the reason for that is the benefits of having a fully covered stent is that it doesn't embed. And that's the biggest disadvantage too, is that it doesn't embed. So there's nothing to hold it in place. And as you all know, the colon has so much peristalsis that things will just kind of flow through. And also if the stent is doing its job and the colon and the stricture is now has now resolved or even partially resolved, that stent's going to migrate. There's nothing holding it in place anymore. That used to be the appropriate answer for fully covered stents is no. And then we started developing this type of stent, which is called a LAMS, which is a lumen opposing metal stent. And if you look, well, fully covered stent, if we went back a little bit, the fully covered stent looks like this the whole way through. It's kind of one big diameter the whole way through. The lumen opposing metal stent is a dumbbell. It's a short dumbbell that has a diameter here, or the diameter longwise of around 1 centimeters. It's it's smaller in the middle, and then it has this dumbbell shape at the edges. And so the caveat to the answer of a technically no, clinically no answer is when you consider using aluminum posing metal stent. So again, it's a bilobed, fully covered short stent with a 1 centimeter distance between the flange, and it needs to be deployed through a therapeutic gastroscope. And so this is one where it's a very short stricture, and you can put this dumbbell shaped stent across this very short stricture. So typically we only use this for anastomotic strictures. So you can see here, this stricture has already been dilated. That's why you see kind of the blood that's there. But often if an anastomotic stricture is recalcitrant, you've already dilated once, you've already dilated twice, and symptoms keep coming back. What can you do in lieu of taking them back to the OR and redoing another anastomosis is to consider this type of stent, the short stent coming across. And the reason why this stent works is because of that bilobe technology, right? You have something on the proximal side, something on the distal side that kind of anchors it in place. But again, it's fully covered, so it's totally removable. But the advantage here is that you have that continual radial force against that stricture. And so the likely rate of that stricture resolving gets significantly higher than just doing recurrent dilations. The nice part about this LAMS, this lumen opposing metal stent, is that you can dilate it after as well. So if you put in a 15 millimeter LAMS, you can dilate it to 15 millimeters. If you put in a 20 millimeter LAMS, then you can dilate it up to 20 millimeters. And so again, another good option for anastomotic strictures mostly. So this is a study looking at LAMS versus endoscopic dilation for anastomotic strictures. Again, what we're seeing is technical success, clinical success, kind of similar, but the number of which, how many patients have to undergo endoscopies is less. Right. So obviously for LAMS, if you put it in, you have to take it out. So that's at least 2 procedures, right? You got to put it in, you have to take it out. You can't just leave it in there. There are times when the LAMS may kind of just pass on its own and a patient may poop it out and be like, oh, I saw something, but that's typically not the case. You have to go and fetch it out. But you can also see that the rate of clinical success may be no significant difference, but the follow-up days, look how many patients, look how long those follow-up days were, right? That they had the same clinical success rate as compared to an endoscopic dilation, right? 700 days of follow-up to have the same clinical success. So it works quite well. And again, adverse events rate 0 here for these patients as compared to 16%. And this is mostly related to bleeding and perforation. So next is the question. So we talked about fully covered stents. Then there are the other indications which are uncovered stents. And so typically we use uncovered stents, not for benign etiologies, but for malignant etiologies. So these are to palliate malignant colorectal obstructions and use them primarily as a bridge to potential surgery. And so the advantages of stenting, an uncovered stent, is it prevents the risk of these high risk emergency surgeries. So patients that come in with a high grade obstruction that need to go to the OR right away, the hope is that we can stent them, buy them some time to kind of to decrease their risk and kind of cool down a little bit before taking them to the OR. It increases the possibility of having a primary anastomosis as compared to a stoma formation, and it allows time for medical resuscitation, allows time for bowel prep if they can tolerate it, and to optimize comorbidities. Now, the disadvantages, the biggest risk is perforation, and we'll go through that in the next slide, but the other risks are migration and reobstruction. There are certain malignant strictures that are so high grade that even if you put in a uncovered metal stent, the vector force of the malignant stricture overcomes the force, the radial force of the stent itself. So there is a risk of reobstruction. There's only so much that the stent can do if the malignant stricture is so high grade. It can also cause ulcerations. And so this is why we say in patients who have uncovered metal stents who say may live longer than 6 months or a year, it's better to take them to the OR at some point because these stents, they keep pushing out. So there at some point they may ulcerate and they may cause bleeding if they stay in for too long. At some point that we may get some sort of complication related to an indwelling uncovered metal stent that's been in there for too long. Tenesmus occurs, especially with rectal cancer, if we're placing the stent just way too close to that anal verge, which is why we say that if there isn't at least 5 centimeters of space between where the end of the stricture is to the anal verge, it's really not going to be tolerated well by the patient. And unfortunately, we only have a matter of days that the stent can be removed if the patient does get tenesmus. Because once it's in, again, it starts to incorporate into the tissue and it stays in. So we want to make sure that there is, at least on endoscopy and on imaging, we have enough space from that anal verge. Technical success rate 81 to 100%. Again, that really depends on the experience of the operator. And here, the 80% is typically when we have these very complex, angulated type of malignant strictures that may require a little bit more finesse in order to get the stent across. Again, the highest rate of success is for lesion lengths less than 5 centimeters, but we do know that we're able to compensate to a certain degree if we do have longer strictures. Remember that the uncovered metal stents come in various lengths. So the most commonly used lengths are 60 and 90 centimeters, but we are able to do kind of overlaying stent and stent. So taking one stent to one degree and then kind of having an overlap and putting a second stent if necessary and under certain indications. So I do want to take a second to talk about the perforation risk because it can be serious. It's a serious complication if it happens, both for you as surgeons to deal with and both for the kind of mindset and we always want to do things appropriately from the endoluminal side. And the reason for the serious complication is it can develop peritonitis or sepsis. It can cause microperforations that takes a patient that may be undergoing chemotherapy at some point and put them at risk for sepsis. And so the causes of these are kind of multifold. One is the guide wire, which I talked about. Again, you never want to force a guide wire, but you can always have, if you force a guide wire through a malignant stricture, you may create a false lumen or a false tract with that guide wire, thinking that you're in the right position. And if the catheter is malpositioned, so again, with all of the stenting, you're putting a wire through, you're advancing the stent across, and then you're opening the stent over the wire. So if your wire is in the wrong place, then your catheter is going to be in the wrong place, and then as the stent opens, it's going to be in the wrong place. The other thing is whether, again, dilation of the proximal colonic bowel, if again, the stricture is too high grade and your stent just can't overcome that, you may have inadequate decompression or an excessive air insufflation. And it's so important that if you do not have CO2 in your endoscopy tower when you're doing these, you shouldn't be doing stenting in the colon with strictures. Air just stays there for so long. And so we really push that if you're going to decompress, endoscopically decompress a stricture in the colon, especially any sort of high grade stricture, it really needs to be done. It really needs to be done with CO2. The other thing to consider while I'm talking about this is if you have a high grade stricture with small bowel fecalization, is to make sure the patient's intubated for the procedure because you are going to put water in there, you're going to put CO2 in there, and you never know what's going to happen as they start to get more proximally dilated. Their intra-abdominal pressure may go up and they may vomit. So again, if you have quite a bit of small bowel fecalization, really think about that and don't just settle that this is a colonoscopy that you can just do it under conscious sedation or MAC. In terms of oncologic outcomes, there's increased risk of local tumor recurrence. There was a small study that looked at doing colonic stenting in young patients with locally not advanced colon cancer, and there was a risk of micrometastasis with putting a stent in. So not enough evidence there to make it into our guidelines or to suggest that we, don't do this for patients who are young. But certainly something to keep in mind that has come across in terms of studies is that some of us may think twice when stenting young patients, especially because it may create micrometastases. Okay. And then as I go back in terms of these types of stenting, these pictures are fluoroscopy pictures showing kind of very complex stents. So what you see here is this tight angulation here, and it's in these patients here that inadequate decompression may happen, that they are likely to feel the stent, that they may get pain from the stent because of how tight these angulations are, but that they may reocclude. So if you have a colonic stent that looks like this, it may work, but just make sure that you want to keep following them longer than you would, say, a stent that's going into a straight portion, because they may reocclude. In terms of technical considerations, so on the right here, you're just going to see the different types of manufacturers and their uncovered colonic stents as of current. Technical considerations, you always need to deploy either under endoscopic view or fluoroscopic view. So remember, these are through the scope. These can be through the scope stenting, but typically they're not. And so you need to do them with straight fluoroscopic view. Through the scope stents are better for proximal or angulated lesions. Again, you have to be able to get there with a gastroscope if you're going to use a through the scope stent, because innately we're using what was technically made initially for esophageal stenting in the colon, which is fine because they're the same type of stents, but you need to do it with a gastroscope. There are radio-opaque markers on the stents themselves that tell you how to position. Now, not all the stents have the radio-opaque markers at the same location. Most of them have a location at the point of no return. So meaning that the stents, as you're deploying them, as your tech is deploying them, there is a point of no return where you cannot recapture the stent. So typically there's a marker both on the tech side, on the device side, and on the fluoroscopic imaging side on the stent itself that tells you, hey, I am at the point of no return. I am not able to reposition. Again, anything before that point, you can start all over again, right? But once you're beyond the point of no return, right, it's gonna be very hard to reposition that stent. You want to deploy slowly. It is not uncommon to need to reposition because your catheter is a much more rigid material, right, than the stent that's in it. So your catheter may look like it's spanning the stricture well, but as you start to deploy, right, the stent accommodates to the space, the bigger space proximally, as it starts to then accommodate to the smaller space through the stricture. So you may need to redeploy, and that's very, very common. You want the narrow neck to be across the stricture. So your structure ideally should be at the 50% mark across the stent. And then be wary that stents foreshorten. So you're using the catheter and you're pulling back the stent, but as you deploy that distal flange, it may jump up back at you. So it's really important that you're seeing the narrow neck of the stricture in the midway point, because then you may deploy the distal part of the flange way too proximally, and then you're going to have to do maneuvers like using a forceps and trying to kind of wiggle the stent back so that your stent is appropriately across the stricture. I talked about this stent in stent concept for very long strictures. Again, I would not do this unless you are very comfortable stenting across strictures, because it typically takes quite a bit of planning, and it's very difficult because the catheters are difficult to deploy into the lumen of that first stent that was placed proximally, right? What you want is the stent to be within the lumen of that first stent. What you don't want is your catheter to go across any sort of lattice, right? And now your stents are kind of crossing each other. The point is that they're within lumen. I don't know if you guys can see that, but like lumen within lumen and not crossing the lattice. So again, if you're not comfortable, like really comfortable, I would avoid stent and stent. You always want to do a plain film or contrast study after. Typically a plain film is enough. And once you put the stent in, you want to avoid crossing that stent. Okay, so what is the timing between stent and surgery? So there's no clear consensus. It's highly debatable, but this was a study looking at 3 different interval groups. One is doing the surgery within 2 weeks of the stent. Group 2 within 2 to 3 weeks of the stent. Group 3 above 3 weeks of the stent. Group 1 required had a higher rate of requiring an open approach versus a laparoscopic approach if you were able to wait longer, and a stoma had a higher rate of stoma creation in the groups that were done who went to surgery quickly. No difference in relating to stent complications, resection complications, mortality rates, permanent stoma formation, or survival rates. So again, if we can really buy them time, at least 2 weeks, their comorbidities can kind of cool down, the bowel can kind of cool down, prep them as much as possible as they can tolerate. They have certainly have some better surgical outcomes. So I just wanted to go through a couple special circumstances in the last half of this lecture. So the first is colon strictures and inflammatory bowel disease. So what I talked about, stenting and balloon dilations, those are pretty ubiquitous in terms of most of our benign diseases, but I did want to talk about inflammatory bowel disease in particular. And so what we're really talking about here is strictures related to longstanding inflammation or fibrosis. I mean, honestly, we're talking about stricturing or fibrostenotic Crohn's disease. And so the most common locations for these types of strictures are in the terminal ileum or the ileocolonic junctions. And there are 3 types of strictures here. So you can kind of see this great drawing in this Best report is you have the first one, which is intraluminal. So you have these inflammatory kind of pedunculated polyps. Then you have a second type of stricture in fibrostenotic Crohn's disease, which is this intramural muscular hypertrophy and fibrosis stricture, which is in the middle here. And then you have a third type of stricture here, which is kind of extraluminal constriction, secondary to kind of creeping fat and lymph nodes. And so you kind of want to know what type of stricture you are dealing with, because obviously an endoluminal approach to this stricture is not going to do anything, versus there's lots that we can do with the second type of muscular hypertrophic type of stricture. And so if we have something in this realm here, endoscopic is more appropriate versus surgical in this realm here. And here we have certain kind of risk factors and predictors for fibrostenotic Crohn's disease, including age, the need for steroids in the first flare, kind of small bowel disease location. This goes back to where the most common location of these strictures are, which is in the TR ileocolonic junction. And obviously, if you smoke or you have deep ulcerations, you're most likely to have kind of Crohn's related stricturing. So what can we do here? And this is where I wanted to bring up endoscopic stricturotomy. And so what does stricturotomy mean? So stricturotomy means that we're endoscopically using electroincision to open or to remove the strictured tissue using electrocautery. And so what this means is we're taking certain devices like these types of knives endoscopically, and we're making incisions to widen the stenotic bowel. And you're either going to do it in a radial, horizontal, or semicircumferential or circumferential fashion. But really what that means is, where do we create those cut lines? So you can see here, I put the electrocautery settings here. It's important to know what type of settings to use, because you want to cut. So you want a pure cut current here. You don't want any coagulation. You don't want to slowly burn anything. You want to cut exactly where your knife is. So you're going to use the endo cut Q313 setting here. It's the same setting if we were to cut and say an ERCP, it's the same setting. And so this is meaning that you're going to use your yellow foot pedal, not your blue foot pedal. And the only time you would use your blue foot pedal here when you're talking about stricturotomy is if you're going to handle something like a bleed or a vessel that you're seeing, then you want to use your coagulation setting. But when you're doing the actual incision, you're going to want to cut. And the biggest adverse event to look for is post-procedural bleeding. And so what you can see here in A, so these are A, C, E, these are all different types of strictures. And you can see, say in A, kind of these radial cuts were made at various locations here, and a more semi-circumferential cut was made along this side here. And I'll show you a video of this later, a great case report of it later. But you can see how taking an electrocautery, you can make incisions along the bowel, right? These are controlled incisions to really open up this this stricture. It's much more powerful than a balloon dilator. And again, in places where we don't want to put a stent, this is a great option. Again, you don't want to do stricturotomy unless you're quite comfortable with electroincision. And so typically not all gastroenterologists do this, not even all interventional gastroenterologists do this. It's really if you're kind of more comfortable going into the third space, as we call it. So kind of going into the submucosal muscular space, because you want to be able to know how to use these knives and want to know when to stop cutting. We don't want to ever cut all the way through muscle. We don't ever want to cut to see serosa because you can easily perforate. Again, the risk of perforation here is technically low because technically these are done in places with high experience. So you have a stricturotomy, a cut, and then there's also a stricturoplasty. So if you were to do a stricturotomy and then you were to actually close the edges in a way that you have controlled the closure, then that's called a stricturoplasty. And so let me just show you this video, this great video. So this is a video of an anastomotic stricture. And this first initially, an incision is made radially here at the 6 o'clock position. So currently what's being performed is a stricturotomy, right? Cutting of the stricture. So you can see here using a knife and cutting through until you really kind of cut quite deep and cut into kind of the circular and longitudinal muscles in a controlled way where you're not seeing any sort of serosa or hopefully not into the peritoneum. So you can see kind of deep cuts here. So you can see deep cuts, 3 deep cuts that have really widened it into a V-type structure. Now, if we were to stop here, what could happen, and let me just stop the video here. If we were to stop here, what could happen is you could restenose at these specific areas here. It likely wouldn't restenose back down to the original size, but it could restenose back to a percentage of that size again, and it may need recurrent stricturotomy. So in this patient, that's what happened. So we had undergone a stricturotomy, had restenose down, had symptoms again. So that's when these authors consider a stricturoplasty, meaning to then close the incisions in a way that they controlled. So if we're going to look here onto the right side, the triangular incision has now opened up. And what they're doing they're taking clips and they're taking this triangular cut, but they're going to close it like this. And so what that means is now the scar isn't going to scar down this way, but it's going to actually scar this way so that the opening at the end is actually significantly bigger and it shouldn't restenose kind of down to a smaller level. So if you can see that on this side here, it's taking these triangular cuts, closing it down this way at all 3 cut sites to perform a stricturoplasty. Again, have to be very comfortable with cutting, comfortable with closure because it can get very crowded in this area, but a great option for patients, especially for patients who have IBD and really fibrostenotic disease. Would hesitate to do this in the small bowel. This is great for the colonic strictures or the anastomotic strictures, but I would just be careful to do it in the small bowel, not to say that it's not being done. So that is it is being done at centers of experience. So what is the data of stricturoplasty versus balloon dilation? Again, you're looking at technical success, very high technical success for both. Subsequent surgeries needed, quite different, right? So more surgeries needed for the balloon dilation group as compared to the stricturoplasty group, and then the risk of perforation when done in expert hands, 0 as compared to 1%, but still 0 is quite impressive nonetheless. What about stricturoplasty versus ileocolonic resection? So here stricturoplasty as EST. Again, the need for subsequent stricture-related surgeries is roughly the same, but the adverse events rate is significantly lower. So those that were predictors for decreased surgery survival, so those that predict decreased surgery-free survival, pre-procedural steroids, those that had multiple strictures, and increased disease-related hospitalizations. So the management for Crohn's disease strictures, this is the current guidelines that we have for practical guidelines for endoscopic treatment of Crohn's-related disease strictures. I won't go through this all. I'll just leave this up here for a second, but these are what they recommend for endoscopic balloon dilation and for electroincision. I would say for more concrete recommendations for balloon dilation as compared to electroincision, because electroincision is a newer technology. This is a good workflow for physicians to go through. So again, if you have a non-angulated, non-complicated Crohn's-related disease stricture, if it's greater than 5 centimeters in length, some of them can consider balloon dilation if it's done at a center of expertise, but most go to multi-team disciplinary evaluation and surgery or one of these novel techniques. But for those that have short strictures that undergo dilation, if they're successful, great. But if they're not successful and they're refractory to balloon dilation, that's when consideration of electroincision should be thought of. And so if it's ineffective, you can still try electroincision, including structuralplasty, or sometimes it's just what we can do. Endoluminal has limitations and we need to go to surgery. But this workflow is a good kind of general framework for what we can use when we're talking about Crohn's related strictures. Okay, next real quick is proximal colonic obstruction. The reason why I bring this up is because clinically we see this not so often where patients have right-sided obstructions. Technically, the success rate is slightly lower than that of left-sided obstructions. And the reason being is location is important. And so it's a long distance from the anus. That means that not only do we have to get there in a tortuous colon, but then the catheter and the guide wire need to go through there and it makes stenting proximally more challenging. And obviously, these patients are not prepped. So sometimes it's very hard to get there just from a practical standpoint, is that the distal colon is not prepped and it takes increased time and expertise to even get a successful outcome in the right colon. And so that's when segmental resection is considered a preferred treatment option. But you did have the new ESGE guidelines in 2020 that upgraded the status of metal stenting as a bridge to surgery in right-sided obstruction. So for some cases, whoever is doing the endoluminal therapies may say, you know what, this is not a great option for endoluminal therapy. And it's because right-sided obstructions are just more difficult in general because of location. But next is diverticular strictures. Again, a very common question to be asked for your endoluminal therapist. Can you put in a stent because of a diverticular stricture? Totally get it. The issue is that stenting has not shown to be a great option here. And so acute diverticulitis causing, transient obstructions, but typically these are patients who have recurrent diverticulitis causing fibrosis and strictures. It's often in sigmoid colon, and they're typically a little bit longer than 5 centimeters in length. And they have this concentric narrowing of the lumen, and then it typically then tapers in shoulders. And so 10% of cases, again, this is inflammation related. So it's hard to distinguish from a neoplasm on CT scan, but where CT scan is very helpful here is it tells us what not to even consider endoscopy at all, which is if there's a fistula, a stricture, a pericolonic abscess, or peritonitis. Really, there's no room here for it to undergo endoscopy. Now, if you really want endoscopy as a surgeon, I can tell you from the GI side, there's always times when we really kind of push the limits of what we do. And typically, if we were to push the limits of what we do, we would require significant multidisciplinary discussion and communication. And we may want to do this in the OR because, say, if there is a microperforation there that becomes a full-blown perforation just from insufflation, they're in the right place to get therapy done by the surgeon if something wrong were to happen. Systematic review of 21 articles for benign disease, most of which had diverticulitis, showing a technical success rate of 94%, but a very high perforation of 12% and reobstruction rate of 14%. And so the use of metal stenting for diverticulitis associated strictures should not be deemed to be standard of therapy. And again, these strictures are very rigid, so they may not fully expand with metal stents. And again, there's nothing really for the stent to grasp into. But again, I know have come across this question quite a bit for my surgical colleagues. So again, a multidisciplinary discussion is always good here, but just know that from the GI side, there is data to suggest to go away from stenting for these patients. These are the last bit of slides I just wanted to put in here. I'm not necessarily going to go through them because I just want to leave some time for questions, but these are the guidelines review of what to do in terms of certain settings. So these are guidelines for left-sided colonic obstructions. And I'll just leave that up here for a second. This is for right-sided colonic obstructions. Again, these have your ESGE guidelines and other guidelines, CRS guidelines. And then your guidelines is related to perforation, migration, and stent reobstruction and timing to colonic surgery. And with that, again, there are many different endoscopic therapies available. Picking the right patient is so important, and the right technique for that right patient is so important. And you need to perform the technique that is best suited to your own skills and to your equipment. So never do anything, don't do electroincision unless you have the right set of knives and you've done electroincision in easier settings that are not difficult colonic stricture settings. And again, multidisciplinary discussions are needed for a large percentage of the cases, and those come natural anyways, I think, in most cases. And so with that, I thank you for your attention, and I hope this was helpful for you all.
Thank you so much. I think that was very helpful for almost everyone on this call, so we really appreciate it. Hey, Jordan.
Hey,
I think we'll let some of the questions trickle in from the chat, but I know we had a couple of internal questions as well, if you want to go ahead.
sure. So I know you put up the slide earlier, which was kind of discussion on the optimal timing in which you should go to surgery with a stent in place.
Mhm.
Have you seen people use stents for the full duration of like neoadjuvant therapy for, like a high rectal cancer? Or how long, I guess, do you see the stent migration rates increase as you start to treat and shrink these tumors as well? Is that something that should be
So
thought about?
yeah, so that one was for uncovered metal stents. So the migration rates typically are pretty low, but the longer the stent is in place, including with neoadjuvant therapy, the longer the risk of ulcerations, bleeding, and microperforations happen.
Mm.
So the answer to your question, Jordan, is yes. We've definitely seen patients who have undergone neoadjuvant therapy with a stent in place. They come in with a high grade obstruction. They're locally advanced, right? They need some sort of therapy. Yeah, we see it in place. The discussion really is how long is this going to be before eventually they can go to surgery, right? And
Mm.
if it's within 3 months, if it's within 3 to 6 months, then those risks that we see with kind of bleeding, ulceration, microperforation, they're not as high as after the 6 month mark.
Right. And what are your thoughts on stenting in cases of extraluminal obstruction? Like that's what I was thinking too.
Yeah.
I don't think
Yeah.
it,
Yeah. I understand. We completely understand that from the surgical standpoint, having a calm bowel is super important. There's just not too much for the stent to hold on to.
Mhm.
Right. So it may be clinically successful for a day or two, but for the risk of going in, then putting in material, right? You want the clinical success rate to be significantly higher than that. So there's just really nothing for it to hold on to. So we see this a lot in, say, patients with ovarian cancer that have really big lymph nodes in the peritoneum, and it's now pushing into the colon. And then you're asked, can you stent? And the answer is it's only going to be helpful for a little bit, then we have a stent to deal with now, and whatever complications may happen with that stent in place, it's likely going to move.
One of the questions I had was in terms of the endoscopic stricturotomy, like where do you recommend people learn that? If kind of not all the advanced GI folks are doing that, is that mostly like in courses and symposiums and stuff like that?
Yeah. So I think courses and symposiums, because they have great models now for kind of stricture models. And so, for example, if you are in your general surgery rotation and you're doing endoscopy, I think you guys call it like your FES rotation or
Mhm.
something like
Mhm.
that. Like doing them in the foregut, like in the esophagus for like recalcitrant GERD strictures or something like that, it's easier to learn, right? Then you're not dealing with all of the torquing motion of a colonoscope, etc. Or if you have a rectal stricture, right? Something really kind of proximal to you, rectal stricture. Those are the easiest to learn. What you want to learn most though is you have to have very good control of your cutting device, and you need to be able to really adequately understand what your plans are, right? Especially because once you start to cut, things start to bleed and then it starts to get a little bit red. You need to know where your muscle layer ends and stops, and where it's too deep to cut, and what to do if you do perforate, right? Because innately, those that are doing stricturotomies, if you do perforate, these people tend to have the skill sets to know how to close these
Mhm.
defects really well, right?
Right.
And so you want to be in a situation that sets you up for good success there.
Makes sense. You're muted.
Muted.
You think I'd know how to do this by now? We've had Zoom for like 5 years. So when you were discussing how low it's possible to stent somebody, would you just mind recapping that? I just didn't hear.
Yeah, so the lowest is 5 centimeters,
Oh,
right?
that's
Typically, like,
surprisingly low. Yeah.
yeah, the lowest. And that is if you're just going to get just a little bit of flange just out, right?
Right.
Ideally, you're a couple folds higher than that. So you can get the best radial force on the stent to actually open it up, right? But if you're too low, then you may not open up well, and then you may get tenesmus.
Yeah. Another question that I just wanted to ask you personally is what do you think about these studies that come out and show these differences in like local recurrence with stenting? I think that the data is pretty mixed.
Mhm.
There's several studies that show nothing, and then there's a couple that show something. And do you think that has to do, and obviously there's really no way to know, but do you think it has to do more with like the length of time that the stent is in place for causing these microperforations or?
I think it more, that's why I brought that up, that like some, especially with this, like the stenting in young patients, right? And the
Hmm.
local recurrence. And that's why I brought that up is not enough for us to change any guidelines, because as you say, it's a very mixed bag of evidence, right? But it's enough for some of us to pause a little bit to want to offer that in young patients. And I think it's just the longer the stent stays in, the more things are going to happen, whether it's microperforations, recurrence. It's just so much force on now a bowel that has undergone chemotherapy, that's diseased, right? That becomes maybe a little bit more leukopenic, neutropenic with therapies, risks of infection, poor nutrition, right? You're putting something that's going to stay and have this radial force on diseased bowel at that point.
Yeah. I found it interesting when you were talking about the length of time that you leave it in for. I was thinking I've seen it used very shortly for like maybe a 4 or 5 day course in a bowel prep and a decompression, but I didn't realize people were like putting it in and then discharging people and bringing them back in weeks. But it makes sense that you could like nutritionally prehabilitate people significantly with that. So,
Yeah, I think, there's a lot of ways to skin a cat, right? And so I think most of us like to make sure that patients are holistically at their best when they discharge, right? And I think
right.
especially at academic centers, we like to make sure, and there's good data to suggest just take, if they are looking good, they're nutritionally fine, they're decompressed, they can take a bowel prep and take them to the OR, great. But that may not be the case for a lot of people. And we may not be seeing them in the institutions where we're at, but innately the data suggests that the longer you can give people, you can suspect that they were obstructed or semi-obstructed or partially obstructed for a while and getting bad nutrition, and you would need
Yeah.
even longer in order to get better nutrition. But
Yeah.
again, these are just studies. These are guidelines. Each patient is so individual, which is why I think as we go through all of the slides, you can even think to yourself, but I've seen a patient where we took them the next day and they did great, right?
Right.
And that's very true. This is the data that we have.
Yeah, it just depends so much on who you're operating on, obviously. I
Mhm.
agree. All right, well, that was fantastic. I really think that having somebody who is on that gastroenterologist, interventionalist perspective coming in and lecturing on this is really helpful. So thank you for taking the time on I'm sure a busy Sunday in sunny California to come and lecture. It was
Thank
Well, of
you.
very,
course,
thank you.
it's my pleasure, and I hope this was helpful to you all. So
We
thanks so
really
very much
enjoyed
for
it.
inviting me.
Later.
Thanks so
Take
much,
care.
everyone.
Bye.